Hey, good morning, everyone. Afternoon, wherever you are in the world. Warm welcome to everyone joining us for this first inaugural event in our new Elementary Decoding the Gut webinar series. So my name is Greg O'Grady. I'll be hosting today. And by way of introduction, my background is as a professor of surgery at the University of Auckland, where I've spent my career specializing in complex GI disorders. And I'm also the co-founder and CEO of Elementary. And our work at Elementary has really been motivated by several years of deep research to better understand where gut symptoms are coming from and how we can better serve our patients by developing more accurate, more useful clinical tests to better inform diagnosis and direct care. And of course, gastric symptoms have historically been a really challenging area of medicine, where I think previous tests have not always provided a complete picture or served us well, meaning that as clinicians, we've often been left with trial and error approaches. So our mission at Elementary has really been to decode the gut, to bring clarity to care by going beyond traditional symptoms and traditional tests into the underlying disease mechanisms. And to that end, we're proud to have introduced a completely new, non-invasive, high-resolution test of gastric function called gastric Elementary. And this test has now been the subject of over 50 clinical studies. And we've shown it really does provide clinicians with objective data to help them move beyond guesswork and trial and error to faster, more personalized care, which we'll be talking about today. It gives me great pleasure to introduce our speaker today, Professor Chris Andrews. Chris is a clinical professor at the University of Calgary and really a world-renowned researcher in disorders of gut function. Chris completed his fellowship in motility at the Mayo Clinic and has since become a leading expert in managing GI motility and sensory disorders in Canada. And Chris has been a true pioneer in the clinical application of gastric Elementary, both in the research and clinical practice. And he often travels and speaks about this test and others. And he's really been instrumental in helping us bridge the gap between this technology and clinical excellence. So Chris, thank you for being here. Really looking forward to your talk, and the floor is yours.
Great. Thanks, Greg. It's a real pleasure to be here, and thanks for joining in today. So I'm going to talk about, the state of gastroparesis and the way we diagnose it. And there we go. These are my disclosures. So, we're going to talk a little bit about the challenge of diagnosing patients with chronic nausea and vomiting. And as you know, gastroparesis is one of those diagnoses we make, but there's a lot of others, including cyclical vomiting, cannabis hyperemesis, and other things. And so it can be very difficult sometimes to tease those apart. So my talk is going to kind of focus on, how we can, assess these patients and get to the right diagnosis and let that guide our management. I'm going to specifically talk mostly about body surface gastric mapping, or the gastric Elementary device. And then talking at the end, I'm going to talk about how to put it into practice and actually how I use it in my practice. So just to remind you, disorders of gut-brain interaction are previously called functional disorders. They're a group of GI disorders that are symptom-based, and they may be underpinned by physiological abnormalities that include motility problems, hypersensitivity, altered mucosal or immune function, gut microbiota, and so forth. And so the main one that we're talking about in the gastroduodenal space is functional dyspepsia, of course, but other chronic nausea and vomiting, things like cyclical vomiting syndrome and cannabis hyperemesis, are also DGBIs and are diagnosed by Rome criteria. Now, functional dyspepsia, as you know, typically does not have nausea and vomiting, but there's definitely a severe end of the spectrum where they may have a component of nausea and vomiting. And so, like I say, it can be very difficult to know how to tease those apart. So in the GI world, and certainly in my clinical practice, when people come to me with chronic nausea and vomiting, it can be a number of different things. And on a population basis, functional dyspepsia is by far the most common thing. Multiple percentages of entire countries, might fit the criteria for functional dyspepsia. But of course, you also have, as I said, cannabis hyperemesis, cyclical vomiting syndrome, gastroparesis, and one of the new kids on the block, ARFID, avoidant restrictive food intolerance disorder, which is actually an eating disorder, but also can mimic a lot of these other disorders, in that people are often very worried about certain foods, or certain foods, textures really turn them off. But if they do eat those foods, they often can get symptoms that are identical to the other disorders. So we've got a lot of these disorders, and the thing about them is that they're all based on symptoms, with the exception of gastroparesis, which requires a slow emptying test, which has a lot of its own pitfalls. So the reality is that we're often trying to just get the flavor of this patient. Is there nausea in the morning? Is it after meals? Is it cyclical or not? And we realize that just having a symptom-based diagnosis is often not that good for actually distinguishing between them. The other reason that this is important is, as you know, functional dyspepsia can be very troublesome, but it is not life-threatening, and it will not affect your ability, your life expectancy. Whereas gastroparesis actually is a very sinister diagnosis for the most part, and it can lead to severe disability, requirement for tube feeding or even TPN, and can really affect your entire life. So we have to be sure that we're getting the right diagnosis, especially when we pull the trigger and make that diagnosis in a young person who's coming to your office with a lot of symptoms. So just to remind you, the formal definition of gastroparesis is it's a state of delayed gastric emptying with no mechanical obstruction. So that means the gastroscopy is generally normal, there's no blockage, and then the emptying is delayed. But as you can imagine, there's lots of situations where the emptying can be delayed, and it doesn't necessarily mean that you have an organic damage or a neuromuscular disorder of your stomach. Obviously, the commonest causes are diabetes, post-surgical situations, and idiopathic, which is actually, in fact, the most common group, the ones where we don't know what brings it on. And so the problem with it is it's very hard to sort of prognosticate what's going on. There's no question that the organic neuromuscular diseases occur. And this is an example, a patient of mine that I saw years ago. He was 33 at the time. He had been traveling in Thailand and ate some street food and got very sick. And so came back, and his nausea and vomiting really didn't get better. And so he was just felt to have post-infectious IBS. Or functional dyspepsia, but over time it became very clear that his gut was malfunctioning, and then a couple of years later, his X-ray shows it all there. He's got massive dilation of both the stomach and the small intestine, and so this is the organic type of disorder that we know exists, but thankfully is not particularly common. And so, of all the people with gastroparesis, most people don't have this. At the same time, since we don't have any good tests to sort of tease out these patients, we actually have no way of intervening early and changing the pathway of this disease course. As you can imagine, once the gut is big and dilated like that, it's usually too late to turn it around, even if we did understand the pathophysiology. So we know that gastroparesis can be manifested as damage to the nerves, damage to the muscles, or damages to the interstitial cells of Cajal, or the ICC cells. And the ICC cells are the pacemaker cells of the stomach that actually propagate and generate that slow wave of electrical activity that allows the contractions to happen. It turns out that most of the time with diabetic gastroparesis, it's probably the ICC cells that are damaged, because they are unfortunately prone to getting damaged by oxidative stress and these types of things that are often very common, for example, in diabetes. Now, but this brings us back to, what can you do about it? We don't do full thickness biopsies on the vast majority of patients just because, it's invasive, but also it doesn't necessarily change management most of the time once the histology is abnormal. But the gastric emptying study, as you may know, it's been around for a long time. It's generally standardized. You eat a radio labeled meal, and it's typically 2 scrambled eggs and a piece of toast and butter and jam. Or you can do it with a different substitute of egg beaters. But it's very controversial in the literature amongst proponents of the 2 different meals, saying that it's you have to have one and not the other. But that does obviously very much restrict the applicability of that test, because a lot of people won't eat eggs or can't eat bread, or they have gluten allergy or what have you. So it is very difficult. But even with the standard meal, You eat that standard meal and you get in a scanner, and you take an image every hour, and the cutoff is less than 10% should be remaining in the stomach at 4 hours. So if there's more than 10% still there after 4 hours, that's delayed emptying. And for most people, that's the sort of the hinge on which you diagnose gastroparesis or not. But that's very difficult. The stomach is a complex organ. It does lots of things. And, it's almost like trying to distill an echocardiogram of your heart into one number. There's just much too much information, or way too many ways that things can go wrong to really try and condense it down into one number. But, this is the way it's been accepted. And the reality is it's the only test that's widely available and relatively standardized. And so that's become the defining test for gastroparesis. But as you can imagine, there's lots of pitfalls in that. And one of the biggest ones is medications. And so if you're on opioids, for example, or GLP-1 analogs, so Ozempic and these types of medications that we know slow the stomach down, it'll slow your stomach down. But especially in people with long lists of medications, we often have no idea, how it affects the gut. And so it's just like in this image here, you've got the stomach duking it out with the medications for supremacy here. Another thing is starvation states. So people with very low BMIs, like in anorexia nervosa, they get very constipated, and they also get slow gastric emptying just because their gut is fairly catabolic. And so, that diagnosing somebody who has anorexia with gastroparesis can really derail their journey to health and to wellness if they really latch on to this idea that they have gastroparesis and not an eating disorder as the cause of their thinness, for example. And then, of course, all these other things, constipation, we know itself also backs things up and can slow down gastric emptying, as well as the other vomiting syndromes. So we're in a bit of a pickle because it's really the only test there is that's widely available to most of us, but it has a lot of pitfalls. And so the Gastroparesis Consortium in the US actually looked at about almost 1,000 patients with functional dyspepsia or gastroparesis, some with slow emptying, some without. And they did an emptying test on all of them at the beginning, and then they did it again after almost a year. And they found that over 40% of patients changed from one to the other. So if you had normal emptying at the beginning, you could have slow emptying at the end, or vice versa. And so the diagnosis would flip from one to the other. And that's a pretty big number. And that makes it very difficult to know what to do with gastric emptying. And their conclusions, and this is again from the NIH-funded consortium, that the results reinforce the concept that gastric emptying studies are of limited utility. And furthermore, others have sort of suggested that if you do major interventions on a patient just on the back of a single gastric emptying study, and what they're getting at is just that one number, switching to very invasive treatments, it might close the door on other things that might work for that patient before you get there, such as management options targeting FD or other vomiting syndromes. So I think it's fairly clear that most people would agree that gastric emptying is not the be all and the end all, and that unfortunately it's a lot more nuanced than originally envisioned. So this brings us to body surface gastric mapping. And so, as you may know, your stomach makes electrical waves of depolarization that kind of go from the upper mid body down to the antrum in a nice controlled way, about 3 times per minute. And these depolarizations are where the contractions happen. So all the contractions have to occur on these slow waves. And if the voltage is high, the contraction is stronger. When the voltage is lower, the contraction is less. But they always happen on these slow waves. And we've known about these waves for 100 years, and you can actually measure them from the surface of the abdomen and track them. And so, they've been actually working on this for 100 years, like I said, at the same time as EKG started. But the problem is that unless you have many electrodes, you will often miss the stomach a lot of the time. And this is a study that was done by the Auckland group that showed that stomachs can have a lot of different ways that they lie, a lot of sort of topographical formations. Some people, they ride really high. Some people, they ride really low. If you've ever had to put in a peg tube on somebody endoscopically, sometimes it's down in the epigastrium, sometimes it's way up there and it's hard to get. And so if you don't have electrodes right over the stomach, the signal is very weak, and so you'll actually miss it. And so unfortunately, with these legacy approaches, it really did not come to any clinical fruition because it was just not reliable enough to say that normal was normal and abnormal was abnormal. So over time, and Greg O'Grady, of course, is a surgeon by training, and so he did a lot of invasive mapping, at the time of surgery, and he would put sensors on the stomach while he was doing other surgeries, of course, obviously with the patient's consent. And from there, they were able to sort of use that as a ground truth to get the cutaneous recordings, and the cutaneous recordings with many electrodes match the serosal recordings very nicely. And so over time, you can see that it's evolved from a fairly prototypical setup into the Olimetry setup, the high resolution body surface gastric mapping, which is an 8x8 electrode grid that captures stomach signal 99% of the time. And so as part of those studies, they also found the difference between normal stomachs and people with gastroparesis. So you can see here on the left that you've got that nice slow wave propagation. And on the right there, you can see that this is what we pick up from the body surface, from the abdominal wall skin. And, when you compare that with gastroparesis, on the right, you can see that it's almost like cardiology in some ways, that these waves are very disrupted, and you can have reentrant circuits, you can have retrograde propulsion, you can have all sorts of things. And so, in the more severe states, this dysrhythmia would probably not lead to any efficient contractions or grinding up of the food. And so this is probably what we think gastroparesis actually is at a very fundamental pathophysiological level. So you can measure that. And then how do you plot that? Well, down below you can see these are what we call spectral plots. And these spectral plots show you, they graph frequency over time. And you can see on the left that somebody with a normal stomach, they've got a very nice strong yellow line at around three counts per minute. And what that shows you is that there's sustained regular 3 count per minute contractions. So that stomach is functioning normally. But on the right, you can see in this dysrhythmic example that there is no sustained frequency of any number. And so that it's all kind of blown up, and that means that the stomach is kind of, I wouldn't necessarily say it's fibrillating, but the concept is the same. The idea is that it's not functioning well, and it's not coordinating. And so this has really allowed us to sort of, look between normal and what we call the dysrhythmic phenotypes. So the gastric Olimetry device is pretty straightforward. As I said, it's a peel and stick array that goes over the belly, and it's an 8x8 electrode grid. It's attached to a reader that collects the data, and so obviously it's non-invasive and very safe. And then the patient also simultaneously tracks their symptoms on an app every 15 minutes, as well as some other information that they input into the app. And then when it's all over, it's beamed to the cloud and provides you with a report. And a standard study is about 4.5 hours. So you place the array, you have a 30-minute baseline with them fasting, then you eat a standardized meal, and then you monitor them for 4 hours afterwards. And again, tracking the symptoms all along the way. And the patient just sits there in a recliner, and so they can, they can watch TV, they can work on a laptop or look at their phone. And so it's fairly straightforward. It can be done in the hospital, in the endoscopy unit, in an office, in a infusion chair, you name it, you could do it anywhere. The meal is standard, and typically we use an onshore drink and a Cliff Bar, but it is variable. It's actually quite robust to changes if necessary. If patient say has an allergy or is only able to tolerate 2 feeds, for example. So it there is a standardized meal and generally a caloric cutoff, but there is some sway there, and that's reasonable because not everybody could have a scrambled egg meal, for example. And so with the reporting, the clinician actually gets not only the spectral analysis and an amplitude graph on the left, but they also get a symptom layout, and that shows the symptoms, the upper GI symptoms over time, and the correlation analysis and the gut-brain well-being survey, which is a measure of stress, anxiety, and depressive symptoms. So this is all put together for you. And so it's providing you with a very objective and physiological based report of what's going on with that patient's stomach. So once again, on the left you can see the normal meal response. So the patient is relatively quiet at the beginning, they eat the meal, the stomach activates, and you get that brighter yellow line, and then it tapers off over time as the stomach empties. And then conversely, on the dysrhythmic or what we think is gastroparesis type patients, you can see that there's no sustained frequency, and that is abnormal. It also has a number of metrics that I won't get into too much on this talk today, but they definitely it does plot out the metrics for you of both the frequency and the amplitude or the voltage, as well as a rhythm index, which is a measure of the stability of that line. And the stability is, the cutoff is 0.25 on a 0 to 1 scale. And so if it's above 0.25, then that's usually sustained enough to be within the normal range. And so, we did collect a bunch of patients, 42 patients with chronic nausea and vomiting, and this is in the early days, and some had slow emptying, some didn't. And we looked at them, and they kind of settled into two main groups. And one is about a third of them were dysrhythmic patients, and their symptoms all correlated with the body surface mapping biomarkers. So it was abnormal, and their symptoms correlated with that. The other 2/3 actually had a normal spectrum, but their symptoms correlated more with psychological measures of especially anxiety and depression. And so ultimately, this was actually a fairly nice discrimination between, organic or physiological dysfunction and normal physiological dysfunction, but probably more a perception or visceral hypersensitivity type situation, which is more consistent with functional dyspepsia. So having a test that actually can tease apart functional dyspepsia from gastroparesis is very welcome because, again, it's objective. It's not necessarily as based on symptoms and patient perceptions, and so that's very valuable in this sort of difficult field. Since that original study came out, we've actually come up with a number of other phenotypes or a number of abnormal patterns. The data is actually very rich, and the discovery is ongoing. And so, if it's something that's of interest to you, we'd love to hear from you because there's a lot of groups that are studying it in almost all aspects and many different patient situations. But we have found these different phenotypes, the dysrhythmic one that I mentioned, and then the other one I'll mention is the high frequency profile. So the vagal nerve actually has a lot of tone that affects the stomach, just in the same way it has on the heart. And it actually keeps that frequency within a very tight range. And so when the vagus nerve is damaged, it appears that the tone is lost and the frequency actually goes up a little bit. Just in the same way if you take an anticholinergic, your heart rate goes up, or if the vagus to the heart is damaged, your heart rate goes up. And so that's actually a very interesting and robust marker of vagal nerve dysfunction. As you know, we don't really have any other good tests for assessment of gastric vagal function other than the pancreatic polypeptide test, which is not super sensitive and hard to get. And so there's a lot of situations where the vagus may be damaged, especially say post-surgically or in neuropathy, and it's nice to be able to have some readout that can actually measure that for you. And then we also have the symptom phenotypes. These are where the spectrum is normal, but the symptoms also group into patterns. And so the continuous profile is where patients' symptoms are continuous, not related to a meal. And this is probably most consistent with epigastric pain syndrome. And the more sensory motor profile, which may be associated more with like a postprandial distress type of functional dyspepsia. We also have a delayed onset of symptoms, which may even be a marker of small bowel disease, although the telemetry does not actually assess any duodenal function, to just point that out. So anyways, we've also done studies that show that certain phenotypes may respond better to prokinetics. And interestingly, this study, which recently came out, shows that patients with a dysrhythmic profile may not actually respond to prokinetics all that well, whereas people with like a delayed onset symptoms do respond well. And that's interesting because if your ICCs are damaged, giving a prokinetic might actually increase the dysfunction as opposed to necessarily helping those patients empty better. So that's yet to be fully elucidated, but very interesting early data that suggests that we might be able to pick up on this. So I'm going to sort of finish with the case and maybe shift into a little bit of management. And again, happy to take questions on this towards the end. But this is a patient that I've seen a lot of. This is a real patient, but this sort of presentation is not uncommon these days. 25-year-old female, history of type 1 diabetes. She's only had it for about 3 years though, but apparently has neuropathy. It can happen, but it's even in people with very poor glucose control, you usually don't get really major neuropathy early on. But in any case, she is on oxycodone for the pain symptoms, also has anxiety and depression, and is also a regular cannabis user. Now, depending on where you are in the world or what state you live in, certainly in Canada, where marijuana, cannabis is legal recreationally, there's tons of people who are using cannabis. And so this woman uses cannabis regularly, and her symptoms are often predominant in the morning. And so she had an emptying test, and it's slow, but it's actually fairly slow, at 28 retained at 4 hours. And so this is that sort of the trifecta, I say. There's 3 reasons that this person could have these symptoms. One is diabetic gastroparesis. The other is cannabis hyperemesis. And the third is it just opioid side effects where it's slowing down her stomach? Or is it just functional dyspepsia? We don't know. There's no question, though, that often if somebody has a history of diabetes and they get vomiting and the emptying slow, we assume it's diabetic gastroparesis just due to the fact that they have diabetes. It's the most likely cause. But it's sometimes hard to prove that. So when we did the BSGM on this patient, she didn't have a dysrhythmic profile at all, and her spectral function looked completely normal. And then when you look at her symptoms, her nausea, and to a lesser degree, that her pain was pre-existed even before she had the meal. And so, based on the normal spectral analysis, I didn't actually feel that she was having, an organic degeneration of her stomach, but it was either more consistent with cannabis hyperemesis or opioid use. And so being able to sort of pull that back and say, you know what, I don't actually think you have gastroparesis. I do suspect that this, it's related to cannabis hyperemesis in some way. And we did focus on cannabis use reduction, and she did get somewhat better, not completely, but somewhat better. And so these as you know, if you have patients like this that you see clinically, they can be very difficult to manage, and sometimes it's hard to get buy-in as well with the cannabis piece. But I felt that this was very helpful for me clinically. A couple of words about cannabis hyperemesis. It's extremely common, and most people who get it probably do have what's called a cannabis use disorder. So usually they're people who are using a lot, meaning generally every day and usually for years. I think we've kind of known that about CHS. We also did assessments of mental health in a survey as part of this study, and definitely very high levels of anxiety and depression in these patients. And then we also looked at patients who went to emergency in my province of Alberta, up in Canada, and and so if you came in with nausea and vomiting and you had a history of cannabis on your chart, or it was mentioned in the discharge diagnosis, then we assumed it was cannabis related. And we did find that there was a lot of females get this as well. So the original reports was that it was very much male predominant. Females get CHS as well. There's no doubt about it. And then some very, you know, sort of, take it with a grain of salt, but we, based on calculations of estimates of how many people smoke cannabis every day, not everybody gets CHS, obviously, but maybe 1 in 200 regular users of cannabis will get CHS. And so if you consider that there's millions of people that are using it daily, that's not a small number. And so, talking about cannabis hyperemesis versus cyclical vomiting syndrome, another small controversy in the literature. A lot of people say that they're two separate things. A lot of, some people say that they're kind of the same. The reality is that it's actually very hard to separate them just by symptoms alone. The hot showers, that people with CHS are often reported to do for symptom soothing. People with CVS do that as well, so that doesn't discriminate between them. And the other problem with CHS, at least with the Rome criteria, is that you have to have been off it for at least 6 months and have gotten better to retrospectively make a diagnosis of CHS. Well, as you may know in your patients, it's sometimes very hard to get patients off cannabis, especially if they have a cannabis use disorder. And so when we tell them you got to stop smoking cannabis, you may be as likely to get them to do that as telling somebody with alcohol use disorder that they just got to stop drinking. It doesn't happen easily, and it's actually hard to get resources to help people that come off it. So long story short is my personal preference is to say that they're probably both the same thing physiologically. There's a lot of, HPA axis dysregulation. That's why they often get such prominent, nausea and vomiting. And it's often starts in the morning with the nausea. And so I think that just the cannabis probably unmasks it in a lot more people than it would otherwise. And so, long story short is, if it's not dysrhythmic, then it probably fits into one of these cyclical vomiting or CHS type syndromes, and we sometimes see other non-specific markers like higher amplitudes in these patients, but that's again a sort of question that's being answered as we speak, and hopefully we'll have more data on that in another year. I won't belabor, how do you get people on cannabis to stop? The reality is if you can get them to lower their intake, even not necessarily stop, but lower their intake, stopping the vaping or the concentrates, which have much higher THC, or switching them to, a higher CBD type of smoked flower, that can often be helpful. So I do have, I could go into all the data looking at the different drugs that we can use for gastroparesis and chronic vomiting, but I just put them all on one slide. And so there are a lot more things out there than metoclopramide and domperidone these days. And another good reason why, doing a mapping study is that, if it turns out that it's not gastroparesis and it might be more like a cyclical vomiting syndrome, then that actually often opens up a lot of treatment pathways that you might not have considered, like CVS treatment pathways or preventative pathways. And so, in any case, there's drugs that if you specialize in this can be very helpful to use. So obviously prucalopride for gastroparesis, probably 2 milligrams, probably not 4. Mirtazapine, an anti-anxiety medication, but also has a lot of 5-HT3 antagonism, so a lot of anti-nausea, anti-pain effect. Aprepitant, a large trial was done in that. The primary endpoint was negative, but it did improve a lot of symptoms in those patients. If you can get it, it can be helpful. And then haloperidol, which, as you know, has been around as an antipsychotic for about 50 years. But our emergency room colleagues are using it all the time now, intravenously, for patients who come in with a CHS attack, because it really attenuates the vomiting very quickly. And that's probably based on its antidopaminergic effects. So in any case, there's drugs out there, there's treatments, and you can fine tune them if you have the right, if you have the right data that tells you, which particular type of nausea and vomiting does this patient have. And then of course there's enterotherapy, which is still available. And it is, it does suffer somewhat from an inability to predict who's going to respond to those. And so We do have some studies that are ongoing to help us understand if certain phenotypes will actually respond better or not. And then for gastroparesis, I'll finish, but just talking about Botox and GPOM. Botox is into the pylorus makes sense. If the emptying is slow, you're trying to paralyze that pylorus to let it open up a bit and let things empty more. But there's actually been 2 trials of gastroparesis, and they were both negative. They were sham controlled. But again, the entry criteria was just based on gastric emptying for these trials, and so it's hard to know if these were done again with stratification based on allometry, whether that would actually be, the outcome would be different. And then finally, GPOM is kind of the new kid on the block. For those who don't know, it's an endoscopic procedure where you tunnel under the submucosa and you cut the pyloric muscle. It's a very elegant and low morbidity procedure. And you just go in there and then use a needle knife to cut the fibers of the pylorus. It's pretty much identical to what they do in the esophagus for achalasia. You just do it on the pylorus instead. And like I said, it's very low morbidity and fairly straightforward to do. The problem is that at about a year, about 50%, sometimes even more of the patients are kind of back to where they started, and that's unfortunate. And it's probably they again don't have a good way to predict which patients should we be doing this on, and so we do have a large international trial ongoing with BSGM to try and predict that. But we do have a bit of a sneak peek, and this is out of King's College in the UK, where they looked at about 32 patients who had allometry before their GPOM. And some very interesting data came out of this, showing that if you had a dysrhythmic phenotype, the gastroparesis type phenotype, or continuous type symptoms, those patients all did really quite well after the GPOM. But interestingly, the high frequency or the vagal nerve type damage phenotype, 0 out of 6 of those patients responded to the GPOM. So that seems like a fairly compelling signal, despite it being a very small series, that there probably are some patients we can do it on very freely, and there's some that we need to be very cautious about doing. And so that could be a real step forward for improving the success of GPOM, which is in everybody's interest, not only for the patients, obviously, but also for the clinicians that do it. You want to be able to do the right test or the right procedure for the right patient. So in the end, and I'll just finish with this, that we still have a lot of diagnostic dilemmas with chronic nausea and vomiting, and gastric emptying studies. It's been the test that we've had, but I think now that we have more data-rich and more physiologically specific tests like body surface mapping, I think that it's great that we can move forward in this field, because there hasn't been a lot of movement in the last decades or two. It is approved in the US, UK, New Zealand, and Australia. Other things, though, that you can think about in anybody with chronic nausea and vomiting is trying to reduce the polypharmacy. Especially these are patients who may be on multiple medications for either chronic pain or mental health. Holding those back or trying to wean them off some of them can be very helpful. At the end of the day, if you're managing patients as an inpatient, when they have flares, the treatment for flares is still supportive. It's still working on glucose control, reducing cannabis, that sort of thing. But hopefully, in time, as we advance both medical treatments, surgical treatments, and the diagnostic ability, I'm really hopeful that we'll be able to really improve the treatment for people with these disorders. So with that, I'll just finish, and we can open things up for questions.
Thank you, Chris, for a great talk. We've had quite a few questions come through. So I'll encourage others to send them through via chat and we can pick them up and ask them to you as we go. So the first question for you was, what type of patient is indicated for this test? How do you choose which patients to do it on?
Well, I definitely I do it on uh, most of my patients now with chronic nausea and vomiting, people who you suspect gastroparesis or any of the cyclical type vomiting situations, or people with a lot of abdominal pain. I'm actually, I'm blessed by having the equipment and to use, and so I actually very rarely order gastric empties anymore. This is to say, like it does take a while, and so it's certainly it's low morbidity. And it's way less invasive, obviously, than any type of manometry test like anteroduodenal. But so I'm not doing it on every patient that I think has functional dyspepsia. But as a motility specialist, the garden variety FD doesn't really come to me anyways. I usually often see second opinions or fourth or fifth opinions, and so it's really helpful for trying to just figure out what's going on with those patients.
Yeah, so I mean, you often see these patients who are quite complex and being medically refractory and come to you after seeing other specialists. But where do you think the test fits in the diagnostic pathway for more general gastro, perhaps, or a specialist?
Sure, absolutely. Yeah. So I think in patients where you're trying to figure out is it just severe functional dyspepsia or is it something more like a gastroparesis? Then I would for sure do it after your scope. After your scope is negative, and you may want to try very preliminary things like for functional dyspepsia, usually like a PPI or a prokinetic. Often the PCP will already have done that. But then I find that would be a good place to put it in, because it actually really helps you triage them as well. Because if it's functional dyspepsia and it's normal, then you can confidently send it back to the PCP for management. If it's really abnormal, then you can often work a little bit harder on either managing it or send it to your motility colleagues for management. So it really helps you decide, is this, especially in a general GI stance, which I do a lot of general GI as well. It really helps me decide, like, is this kind of my problem to manage, or is this back to the PCP? That's pretty helpful. There's actually another angle that it's where it is very helpful is also for my surgical colleagues. I work a lot, obviously doing esophageal manometry and so forth. I do a lot of work with my thoracic surgery, upper GI surgical colleagues. And so, trying to help understand, if they've done a surgery and the patient has a lot of symptoms, we can really help understand is a vagal dysfunction and that sort of thing. And that can also help them decide if they want to do a redo or not. And so that's probably another big group that I see as a motility specialist. But I do find that, having more data and more specific data like this is never harmful.
Right. Yeah, and a couple of people have asked you to elaborate further on the relationship to gastric emptying testing and where this test fits alongside it as a complementary test. Does it replace it? Does this test measure gastric emptying? Can you comment on that?
Yeah, no, for sure. They do measure different dimensions. And so, the nice thing is in many ways, they can be complementary, and because as the gastric emptying is a sort of, you know, umbrella test that sort of gives you an overall picture of, can the stomach empty or not? And sometimes if you know what the physiology is, you want to know how is it affecting the emptying, and so having both of those data can be helpful. It does not measure gastric emptying directly, although there are some patterns for sure that we see that are consistent with gastric emptying, like the delayed meals responses, for example. Um, and so sometimes you want all the data you can get, but at the end of the day, the empty test is a lot more fallible. It's a lot more variable, and it's really dependent on medications and if they vomit, it invalidates the test. And so it's actually less helpful in my hands for sure than the elementary is.
Right. And another question is, does the test work in obese patients?
Yeah, so it's approved for BMI up to 35. But, speaking from experience in other published trials, that it can be used above 35. You just need to, we say, to interpret with caution, just because it was validated up to 35, but they've had success in doing it on people with BMIs much higher than that. And really, it really kind of depends on whether they're more pear-shaped or more like a marshmallow shape, again, if you will. So if it has to go through a lot of adipose tissue, then the signal gets, the more adipose, the more attenuated the signal gets. And so, but if they're more, pear-shaped and there's less adipose in the upper epigastric area, then you can often get perfectly reasonable signals.
Yeah, and maybe I can also add to that that the metrics do compute based on the patient's individual BMI. So for the amplitude, for example, it's adjusted
Exactly.
the patient's BMI.
That's
So
yeah, that's right. Yeah, I should mention that. So it does adjust for that up to 35.
yeah. Um, there's a question here. Does it differentiate between FD and gastroparesis, or at least how do you use it to answer that question?
Yeah, well, I mean, again, since the state of the art is actually that the gastroparesis and FD are more concepts than anything else, right? The gastroparesis with slow emptying, it doesn't actually get to the heart of what kind of damage is the stomach actually experienced. And so I definitely feel that this is actually a much more robust way to say that yes, there's neuromuscular dysfunction of the stomach, or is it something external to the stomach? And so FD is usually the stomach works okay, but the sensory apparatus or the processing apparatus is altered. And so I kind of think of it like a car and driver. Okay, so if you see a car swerving all over the road, the gastroparesis is the car is broken, and FD is more it's more the driver is the problem. And so, I think that does actually really help me figure out, like, if you've got a degenerative neurological condition of your stomach, that portends a lot poor prognosis, and I'd be willing to take more risk in terms of managing that, putting in tubes, doing G-poems and that sort of thing in somebody with FD, which is essentially equivalent to IBS, where they, they have bad symptoms, but they will not, they won't die from it, if that makes sense. So yes, I do. I essentially do use it to distinguish between FD and gastroparesis, but I'm sure there's a lot of people in the field that would probably feel otherwise. But I think it's a lot easier to do this than to just base it on symptoms.
Yeah, I really like the car and driver analogy, gotta say. And more, I hear what you're saying. It's kind of there's more motor patients and there's more sensory patients. And these tests, we're really trying to get at who are the real patients with a motor disorder, so we can separate them out from the sensory patients, and accepting there's a bit of overlap, but trying to do that as much as possible to kind of direct therapy. Is that kind of what you're saying?
Yeah, exactly. And
Yeah.
I think that because it also opens up new avenues. If on the sensory piece, there's a lot of medications for neuromodulation, and also psychological treatments, CBT, and these sort of things that could be very helpful. And GI, we actually underutilize those things, and probably mostly just because we're not often confident that it's the right patient necessarily. But if we can confidently sort of steer those patients towards the right therapy, then that's a bonus. That's an advance in my mind. And then obviously the motor ones you would kind of treat differently with more structural interventions or prokinetics or what have you.
Right. Maybe there's time for just a couple more. There's a quick one here about what happens if someone vomits during the test. I know that's a problem during gastric emptying. Do you find it's a
Yeah,
problem during?
exactly,
Yeah.
exactly. Thankfully it doesn't happen. We try to tell patients not to. We want them to eat as much as the meal as they can, but if they can't, like, we sure don't want them to vomit. It does happen sometimes. So recent paper has come out showing that it doesn't invalidate the test. What often happens is the stomach does go quiet for a period anywhere from sort of 5 to 10, 15 minutes, and then often it resumes. Usually you don't vomit out all the caloric content. So it actually resumes, and it carries on. And so over the course of the whole study, it actually doesn't necessarily change your phenotypic ability, and so that's super helpful. And compared to gastric emptying, of course, if you vomit, it's immediately invalidated and it doesn't give you any relevant information. So vomiting is not a problem. I think there's also a marker on the app where they can mark if they vomit, and so that actually makes it fairly easy to know where that occurred, and just you can almost mentally cut out that period. Yeah, so I think the nice thing is it is robust in that way, that there's variability in the meal. Just in the same way some people can't eat eggs, they say they're grossed out by eggs, you force them to eat eggs and they'll vomit. Whereas, with our meal, if they can't, if they're gluten free or they're vegan, you can just choose an alternative that suits their needs, as long as it kind of matches the calories. So the meal is better, and then the vomiting, it's more robust to that. So that's why the reproducibility is really outstanding, actually.
Great. Yeah, and an interesting question here related maybe to your case you presented. Maybe it's the last one we have time for. Have you looked at how cannabis and opiates affect gastric electrical activity? Obviously, this patient had problems with both, but do we know how the drugs themselves are impacting the test?
We don't. We do know that drugs can affect some of the things. For example, we did a study in GLP-1s, and we do know that that reduces the voltage of the stomach. Long story short, though, is we haven't actually looked specifically at opioids or cannabis yet. I do believe that might be in the works for opioids in particular, and I think that would be very useful information. I wouldn't say that it sees through opioids, in the sense that we still do recommend that if they can stop them, they do for the study, just to sort of get a baseline reading as to what's going on. But as of yet, we don't have that info to know exactly.
Yeah, I've seen one group who was studying the effects of opiates on stomach function, and they were showing pretty profound suppression of the amplitude. So it's something, yeah, I agree to look out for, and hopefully patients can mostly stop their drugs if they can.
Yeah, for sure.
Yeah. Well, thanks so much, Chris, for a great presentation and excellent series of questions. We really grilled you. And thanks to the audience as well for their participation and forwarding lots of good questions through to us. Really appreciated your time today.